Okay, good morning, everybody. It's great to start on time. I was explaining to Mira about Africa time, but we thought we'd bypass that and start on time this morning so that we get finished on time. So it's my very great pleasure to welcome you all to Cape Town. My name's Jeanette Parks, and I'm the head of the Oncology department at the University of Cape Town. So I hope that all of you that are visiting our beautiful city have had a bit of an opportunity to take a look around, whether it's the mountain or the beaches. We hope the weather's been okay this time of year. You can never really tell, although we do have a saying in Cape Town is if you don't like the weather, wait for 5 minutes because it's going to change. But anyway, today looks like a good day, and I really hope that all of you have had a little bit of an opportunity to take a look around. I would really like to extend a massive thanks to Mira and her team from GHOS, who have put together an outstanding meeting. We've run the workshop for the last 2 days, and I think you'll all agree that it's really been extremely worthwhile, and now we're looking forward to the main part of the meeting. Mira and her team have rallied to raise the funds to bring all of the delegates here to Cape Town to this meeting, as she does every year, to run a meeting somewhere in Africa, and to bring the expertise of a very large panel of people to Africa to share their skills and their expertise with the African oncology professionals. So a huge thank you to you and your team, Mira, both for the expertise of the panel that you bring and also for the funds that you raise to bring the delegates here and the standard of the meeting. Thank you. Thirdly, I'd like to say a big thank you to the speakers. I know there's not a lot of the speakers here in the room, but for those that are, we'd really, really like to thank you for giving of your time, for giving of your expertise, and for giving your funds, because all of the speakers have personally funded their trips here. So if the delegates could please give a huge round of applause to all of the speakers. Lastly, I'd like to speak to the delegates that are here from all over Africa. I'd like to say that you are part of a very select group of oncology personnel. We don't have enough oncology personnel in Africa. So attending a meeting like this comes with responsibility. The responsibility means that you need to make sure that you learn everything that you can when you come to a meeting like this, everything that you can, that you engage, and that you take home what you've learned and you teach it to other people. It's not enough to just sit here and learn. You actually need to go home and teach, because we don't have enough oncology personnel in Africa. Henriette's going to be talking a little bit more about that in one of the upcoming talks. But you really do have a responsibility to go home and to teach others what you have learned here, to advocate for oncology resources within your own countries, whether that's human resources or equipment, to document what you are doing as a baseline for yourself to see whether you're improving, but also to get that information out there into the oncology community. We just don't have enough research or enough information coming out of low and middle income countries to be able to show what we're doing and what we're not doing. We've got a massive patient load, and we need to be able to share with others. Some of the stuff we're doing is really innovative. Some of it lags far behind the global north. So we've got to be able to document that kind of thing. Okay, so I'm going to hand over to Mira now, but my parting words is just to encourage full participation in the sessions, lots of engagement, lots of questions, because the team's here for you, to teach you and to engage with your issues in your countries and to learn what you know and to help teach you what you don't know. So thank you, and over to you, Mira.
Thank you, Jeanette. And yeah, there are a number of people here to teach, but we also are here to learn from you all too. So please remember as we go through the meeting. So to welcome everybody, on behalf of Radiating Hope and the Body Agency, welcome to the fifth Grader Horn Oncology Symposium. We started the symposium 10 years ago to serve as a platform to exchange knowledge, ideas, visions, and experiences to advance radiation therapy-related care in the region. Having held GHOS in Moshi, Mwanza, Zanzibar, and Dar es Salaam, this time, in collaboration with Access to Care Cape Town, we have brought a part of the Greater Horn to South Africa. With enormous gratitude to the sincere efforts of Jeanette Parks, Hester Berger, Elaine Smith, Nanette Joubert, and the entire Access to Care Cape Town team, in addition to this main meeting, we held a 2-day pre-conference workshop at their unique training facilities for 40 radiation oncology personnel, and it's just been an absolute blessing to work with you guys. Thank you. This portion of the meeting included interactive case discussions and a hands-on head and neck contouring workshop under the guidance of Beth Beadle. Beth, I think you're here. I know you spent countless hours putting it together. Thank you. For this conference, throughout Africa, we have representation from Ethiopia, I think, right? Yes. Kenya, Rwanda, Tanzania, Uganda, Zambia, and of course, here in South Africa. Did I forget any African countries? No? Okay. We also have speakers from the Netherlands, the United Kingdom, and a bulk from the United States. As Jeanette mentioned, the diversity of this symposium is possible significantly because of all the North American and European attendees who fund their own trips. Via registration, they contribute to cover symposium expenses so that this group could be here today. Thank you all so much. We know the investment to attend a meeting in South Africa is not small. We sincerely appreciate your time, energy, and dedication. Some folks have flown, I think, 36 hours for a 25-minute talk, and they're only here for 3 days. Besides the workshop, what sets this GHOS apart is that we have close to 40 registrars in the audience. A warm welcome to all of you. There's a stellar variety of talks over the next 2 days, ranging from clinical presentations to QA treatment planning discussions and projects on advances in radiation therapy-related care in regions of need. Before starting the meeting, though, just a few more people that I'd like to thank that have been key pieces in putting this meeting together. Deb Rorick and Linda, you all have received many emails from them. They have seamlessly put together logistics of this workshop, the pre-conference workshop, as well as all of the lodging and transportation. We've had 3 residents work with us this time. Some of you may remember Sandos Al-Khatib from last GHOS. She's got a little one on the way, so she couldn't physically be here, but I do extend my thanks to Sandos. And Asim Bhatnagar and Agnes Awangwo have been absolutely priceless here on the ground. Thank you both so much. Wayne Jenkins is the Vice President of Radiating Hope. His support has been unwavering, and he's increased our visibility quite a bit. And really, Tom Ladd, the Executive Director of Radiating Hope, he's standing in the back over there. He is, you can't miss him, he's the tallest guy here. He is really the invisible force behind all that Radiating Hope does, so thank you so much, Tom. There's been a slight schedule change because of visa issues and travel issues. The new schedule is on the QR code that's on the tables in front of you, so please just scan that if you want to know what the most recent schedule is. And as you all know, we're going to keep all strict times, right? Yeah. So when we call you in from the breaks, please come on in so we can get the program moving. There will be a group photo right before lunch, so please stay for that. And then we will kick off the symposium with an absolutely perfect topic. I'll invite Dr. Henriette Berger up here to discuss access of radiotherapy and capacity building in Africa. Thank you all so much.
Thank you very much, Mira and Jeanette. Good morning, colleagues, ladies and gentlemen. It's my privilege to start this amazing, well, I wasn't part of the workshop, so the 2-day conference, with a talk on access to radiotherapy and capacity building. So I'm Dr. Henriette Berger. I am the HOD of Radiation Oncology at Stellenbosch University, which is also here in Cape Town. So just a few disclaimers. I work in a public academic hospital. We are a Varian and an Electa center, and those are my grant funders. Another disclaimer is that in putting together this presentation, I really tried to synthesize the information that is out there. So please excuse me if I took a more is more approach, but I still want to apologize if I left anybody out or if there are any projects that I didn't mention, and you're welcome to come and talk to me afterwards so that I can update my slides in case I have to give it again. So let's start by looking at the African cancer landscape. Because it is slightly different from the landscape in the rest of the world. What we know, and especially from the Lancet Oncology Commission report published in 2022 by Will Ngwe and colleagues, is that we are looking at a doubling of cancer incidence and mortality rates between now and 2040 in Africa. We also know that low and middle income countries will carry 70% of the global cancer mortality burden. I've put there some of the reasons for this rapid increase in the cancer incidence rate, and a lot of it has to do with the high rate of virally driven cancers that we find in Africa. We also see that there's increased life expectancy, both in our HIV negative and our HIV positive patients now. And we have obviously environmental carcinogens like agriculture coming from the mining world and the increase in westernized lifestyle. We also have evidence to show that there are some genetic predisposers that modulate the clinical presentation of patients arising from Africa, as we see in prostate cancer. So just to give us a little bit of reference, I'm going to be using a few terms that I just want to familiarize all of us with. The first is this concept of the World Bank GNI per capita classification. And so here I've given you a map of low income, lower middle, upper middle, and high income countries. And what is clear to see is that Africa is basically the home to most of the low and lower middle income countries. The table on the left just shows the population density distribution, and what we do see is that Africa, and specifically sub-Saharan Africa, only contributes about 15% of the global population. But what I would like you to note is that the African population is the one with the highest growth rate as we project population densities between 2022 and 2050. But GNI per capita is not the only way to describe the financial situation in a country. So another element that we can look at is how many, or the percentage of people in a country living under the international poverty line. And that is defined currently as $2.15 per person per day, which is quite low. But what we see is that globally, and if you look at the black line in the middle of the graph on the left, 8.5% of people in the world are living under the international poverty line. In sub-Saharan Africa, however, if you look higher up to the light yellow line, this value rises to 37%. And while we said that only 15% of the world's population live in sub-Saharan Africa, 57% of the global poor live in sub-Saharan Africa. And what we see, as you can see on the left, there is a trend towards improved, let's say, less poverty across the world. You'll see a slight dip in 2020 because of COVID, and definite reductions in the improvement in poverty after COVID. We find that many countries, even though they've shifted from, for instance, being a low-income country to a low-middle-income country, the reality is that the percentage of people living under the poverty line in those countries have actually increased. So again, the World Bank data is not telling us the full picture. On the right, we see elements like the Gini index, which looks at disparities in access to finances, even within a country. And we know that South Africa has the highest Gini index worldwide. Another concept is the Human Development Index. And this map also indicates, in terms of the color shading, the key dimensions of human development, which are characterized as a long and healthy life, a good education, and having a decent standard of living. So you'll see that we refer to that as well when we talk about access to radiotherapy. Okay, so let's get back to the topic of cancer. And here I'm showing cancer mortality to incidence ratios for, on the left, the different regions of the world, and on the right, the World Bank monetary classification systems. So you will see that Africa is at the low end at the bottom of the left chart. And what I'd like you to note is that Africa actually has a relatively low cancer burden when compared to the rest of the world, but that the mortality to incidence ratio is one of the highest globally. We're looking at a mortality to incidence ratio of 0.64%, with some variation across African countries, whereas in high-income countries, on the top right, we're looking at a MIR of 0.3. Some further points about the African cancer landscape is that the economic and social impact of this incidence and mortality rate is quite significant and increasing. We see on the chart on the right that we have a large group of our younger adult population being affected by cancer, and this is mostly due to virally driven cancers, and they also have quite a high mortality rate. These are people that should be economically active. These are people that should be caring for families, mothers with young children. The study by Sharma et al., also published in 2022 on mapping cancer in Africa, also showed that the Human Development Index actually explained 75% of these variations in 5-year cancer survival between different countries. We know that a greater proportion of patients in sub-Saharan Africa present with advanced disease. And when we look at funding and the availability of finances, Africa, even though it carries 4% of the global cancer burden, it only has 3% of the health workers, and it spends less than 1% of the world health expenditure on cancer. Another element that we shouldn't forget is data collection. And it shows that only 1 in 5 low and middle income countries have the necessary data to derive cancer policy. So just to bring ourselves back to the types of cancer that is common in Africa and sub-Saharan Africa, we know that cervical, breast, and prostate cancer will always top the list. Here I've shown about the top 10 cancers. What's interesting is that the relation between breast and cervical cancer is different when North Africa is excluded from the equation. Also important to note that cervical and breast cancer predominantly affect women, and prostate cancer predominantly affects men. So we know that half of all cancer patients will need radiotherapy as part of their treatment, either for cure or for palliation. And so what I've indicated here is the different roles and different sequencing patterns of the use of radiotherapy in these common cancers. We see it used in the definitive setting, in the neoadjuvant, adjuvant, or salvage setting for the cancers listed here, and basically in the palliative setting for every cancer possible. And this would include external beam radiotherapy, brachytherapy, as well as unsealed source radiotherapy. So when we talk about radiotherapy utilization, the term radiotherapy utilization rate has been defined to show the number of patients in a population that will require radiotherapy as part of their cancer treatment. And Africa actually has the highest rate at 54%. And this is mainly due to the late presentation, but also due to limitations in access to surgical care, because you can appreciate if a cancer presents earlier, the focus of their treatment is more surgical versus our advanced cancers where combined modality treatment is used. Africa has the fewest resources available for radiotherapy. It's only servicing about 34% of the need. And when we look at Africa as a whole, we actually also see an unequal distribution within Africa, with 82% of the radiotherapy machines in the north and in South Africa. Through DRAC, we know that there are 99 brachytherapy facilities in 22 countries, but again, a focus on the North and Southern Africa. And the reality is that there are still 20 African countries, or even just more than 20 African countries, that have no radiotherapy facilities. And relevant to our conference this weekend, 3 of those are in the Greater Horn of Africa. So an interesting perspective of this is that technology adoption has actually been relatively, let's say, keeping up with the rest of the world across Africa. But the one place where there is an exception is in radiotherapy. So, as I said, I'm trying to bring a synthesis of the concept of access to radiotherapy. And therefore, I've made this table, which helped me to see the bigger picture. And in a sense, I want to invite you to look at this table, where I've tried to explain how we access radiotherapy by giving our patients the right treatment at the right time, in the right place, by the right healthcare professional, with adequate support, and at the right price, in keeping with universal healthcare principles. So, in a sense, this shows us both the direct and the indirect resources that are required to ensure adequate radiotherapy access for our patients. And I actually feel that this is a motivation, because it shows so many places and opportunities where innovation can be used to improve access. We're looking at number of machines, whether that is 3D versus advanced techniques. If we look at brachytherapy, are we able to offer our patients 2D or 3D brachytherapy? Do we have access to intercavitary versus interstitial? Do we have these indirect resources available? Diagnostic facilities, pathology, planning services, chemotherapy. When we look at the right time, that is the topic of a whole separate presentation. And it means different things whether you're trying to cure or to palliate a cancer. But giving the patient the treatment in the therapeutic window is something that especially South Africa has been struggling with lately. In terms of waiting times for radiotherapy, where many of the academic centers in South Africa are not able to offer radiotherapy treatments within the therapeutic window anymore. We're looking at all the different members of the multidisciplinary team that need to be involved, support services to our patients, and in terms of the place, the fact that radiotherapy services, even in South Africa, are very much centralized in metropolitan areas. So even though South Africa has a high number of radiotherapy machines, a huge part of the population, due to distance and the inability to fund their own traveling, still don't have access to those radiotherapy machines. So in a sense, each country will have a different profile in this table. And I think the work that we need to do, Prof. Parks inspired us to all get involved in increasing access to radiotherapy, is to see in your specific setting which of these elements are playing a bigger role, or maybe which of these elements are actually changeable. Some we're not able to change, but which ones can we change, and to work on those. So, again, as part of my preparation, and I learned a lot doing this presentation, thank you very much to the organizers, to help me understand what the need for radiotherapy is, I've just put this down because you always have to look at resources and demand. And so you're looking at your cancer population, your utilization rate, the average number of fractions per person, which in Africa is 16, because it ranges from 1 for palliation to 37 for prostate cancers, who haven't adopted hyperfractionation yet. We won't talk about those people. And then your demand metrics, which includes the number of machines you have access to, which is often defined as machines per million people, operational hours. Many low middle income countries where there is, let's say, limited machine capacity have opted to operate 22 out of 24 hours of the day, with RTTs working shifts. So this is also a variable in the equation of getting access to radiotherapy. The number of work days per year, the number of fractions that you're able to deliver per hour, and the reality that we all face of machine downtime, whether this is for quality assurance or for repairs. So again, interesting balance that needs to be found. So I just wanted to point out some of the disparities in machine distribution. I want to point you to the ratios in the Western world, which go up to about 7 machines per million people, and you'll see it's the same for the high-income countries, but that the ratio is much lower in Africa, actually less than 0 in larger parts of Africa. If we break this down into the separate regions in Africa, the Lancet Oncology, the publication by Elmore in 2021 showed us, and here I want to point out that even in Southern Africa, even though we saw an increase in the number of radiotherapy machines in Southern Africa, the ratio of coverage actually decreased. You'll see there it went from 88% to 65%. And another interesting fact that I find particularly important for South Africa is that if you work out the ratio of public access in South Africa versus private access, it paints a very different picture, with patients in private actually having a 4.3 ratio of machines to million people, but in the public it's 0.2. Brachytherapy, on the left we show the burden of cervical cancer in Africa, and on the right you can see that this is not reflected in the machine distribution of brachytherapy availability. What will it take to improve access to radiotherapy? On the right you see a graph that shows the percentage increase in investment that is required. So even though you can see that, and I want to focus you on the blue bars, the dark blue bars, which represents Africa, you can see that there's a more than 100% increase in investment across all levels, whether it be machines or staffing. But if you look on the left, and especially on the little chart in the middle here, you'll see that the actual size of the investment in billions of dollars is actually not as big as it might be for other regions in the world and other low middle income countries. So I think what we want to bring across here is that even though we know that initial investment cost, infrastructure cost is quite significant for a radiotherapy service, Atun and colleagues actually showed that the operating cost of a radiotherapy service in a low-income and a low and middle-income country can actually be much less than in a high-income country, making it a very cost-effective way of managing cancer. So the starting point of any attempt to control cancer is a good national cancer control plan. And I've given there the elements of a national control plan. What I wanted to point out is that even though we as radiotherapy staff are focused on the treatment section, we should not forget the importance of having adequate prevention and screening programs, early diagnosis, correct staging, and palliative care. because there's a knock-on effect. If those services are not in place, it changes the profile and the radiotherapy utilization rate that we receive on the treatment end. So even though it's not our primary focus, it would benefit us as the radiation oncology fraternity to also invest in those areas of the National Cancer Control Plan. Unfortunately, we see that only 37% of countries have a national cancer control plan, and only 65% of countries have a cancer registry. My time is up, so I have to be very selective about what I tell you now. Negotiation. Okay. So, again, staffing challenges are different for each country in Africa. I've just highlighted a few here. In general, we see our staff move out of Africa, whether it be for better working conditions, immigration, whether they feel they're not being remunerated according to market levels. We see that only less than 10 countries in Africa actually have a radiation oncology training program, but interestingly enough, even though South Africa has radiation oncology training programs in nearly 8 of its universities, less than 75% of South African graduates end up working in the public sector. Most move into the private sector. We know that the IAEA recommends an oncologist per every 250 new patients, but in Africa, we see 31% of our oncologists seeing 500 or more new patients a year. I'm going to point out medical physics, where there's also a lack of training programs. South Africa stopped training chemotherapy nurses for about 3 years and has only recently instituted that program again. And another thing that's become quite relevant for our center is equipment service engineers. And there you always have the balance between engineers linked to the vendor company or engineers that are actually locally based and linked to the cancer center. So again, we are here to talk about capacity building. And I'm just going to end, because I don't have any more time, with looking at what capacity building actually means and where we have opportunities to build capacity. If we, and I've chosen to look at the cancer service platform on an individual, a structural, and a political and institutional level, where people can support us and where one can invest either your time, your funds, your expertise, knowledge and ideas would be to support policy, establishment of good policy, improving access to infrastructure, giving technical assistance, whether that be to improve patient flow, management and regulation of health products, supporting the interdisciplinary approach to cancer care, supporting data collection and data monitoring, or supporting management of change. Because often in our setting, that is what is required to adopt a new technique, whether it be advanced radiotherapy techniques like hyperfractionation or VMAT radiotherapy. The change has to be managed. Also then finally, skill strengthening. And this applies to both healthcare professionals, but also to the population. Whether it be to train community workers or educate the population about prevention and screening methods. And as the quote at the bottom shows, capacity building is a long-term process. It's not something that happens overnight. And the aim is to improve the ability of us as individuals, as groups, and as organizations to generate positive change and perform better to improve public health results. I'm going to stop there.
Thank you so much, Dr. Berger. Next, I'd like to welcome Dr. Thuran Naiker, who will discuss pediatric radiotherapy in Africa.
Oh, good. Thanks, everyone. I'm Thuran Naiker. I work at UCT. I was listening to Henriette talk and thinking, I hope Jeanette feels satisfied, because we were both her registrars at some point, and here we are showing maps of Africa and the world. So if you don't feel like you had a few converts today, it should be convincing for you. So thank you, Henriette. So Henriette's outlined the sort of cancer burden in the continent. I have a little bit less time. I'm just going to point out a few interesting things about the pediatric world, and then see where we go from there. So that's UCT. I stole this picture from an ophthalmologist with a drone, and with his permission. Okay, so children. We had a few great talks in the workshop, and I know Arnold's going next. But children are not big adults. We need to see them differently. They get different cancers and tumors. They're more likely to be cured and live long, and therefore the price of survival for children is a big one, and we need to manage that. And then radiotherapy techniques, as we know, the different techniques evolving, proton units, VMAT, they have bearing on what we do. So we need to see children as their own, I want to say entity, but I don't think my children would like that very much. Okay, and a child in Africa. So that's children in general. What does it mean to be a child in Africa? So a child in Africa has different things to face. The diseases are different. You saw Henriette point out we've got several cancers that are driven by viruses. And for us, it starts at baby level when we look at our Road to Healthcare card, the immunization schedule. So are people adherent to these? And do we have all of the immunizations we should have? I mean, we recently started rolling out a few years ago the cervical cancer vaccination, but I know the uptake to that's been variable. So education regarding immunization is also an issue. And then our resources. I don't know if I need to say too much more about the resources. I'll say a little. But of course, if you don't have the resources that other hemispheres, we'll say, have, or those resources are not managed well, you affect diagnoses, you affect treatment. So where are the children? Jeanette, I'm sure she says this when she's sleeping. Where are the children of the world? I try to change the question. So which continent has to look after the most children? And there are lots of children. There are children in India, children in other parts of Asia. But if you look at the age, let's see if I can use this pointer. There, the dark blue. That dark blue bar is the tens and teens. So we have the youngest population and the worst mortality. So you'll know from the World Health Organization and the Global Initiative for Childhood Cancer that only about 20%, if you take the whole continent, survive their childhood cancer, whereas the high middle income countries have a much better survival, but far fewer children. I'm hoping you can see the colors, but don't stress if you can't read it. So what are the resources available? This was a nice article that was published by PsyOp Global, a few local members publishing this, so Jennifer Heel and Prof. Davidson, and they're just showing what resources are there. So the orange Africa map is of the chemotherapy available, and the darker colors are available continually. So if you look at chemotherapy, we're not doing too badly. Probably chemotherapy administered by adult oncologists, not specifically ped oncologists, but still available. The green is pediatric surgery. So again, we look good in the tip of Africa and some parts of the north of Africa, but big gaps in the middle, and the greater horn of Africa is particularly struggling with experienced pediatric surgeons. Pediatric oncologists, so specifically ped-onc trained chemotherapy doctors who manage children, also quite well when you look at the blue continent. The light blue are the places that are struggling. But again, when it comes to radiotherapy, always the center is the one struggling. As you heard Henriette say, 20 countries still without radiotherapy services. So, and we know we need radiotherapy to cure children and to palliate children. So that's a problem. Our starting point's a problem. This is a slide from, now I have to remember if it's Jeanette or or Esther. They both gave me slides, but I'll thank them both at the end. But the current radiotherapy machine stats, I won't spend too long on this. I think Henriette covered some of it, but 195 units, no proton units. This conversation about the proton units taking up half of my PED consults these days. I'll talk a little bit more about that just now. About 103 of the MV units in SA, and the rest of Southern Africa is coming behind us. And some of the direct data there. So coming back to the Global Childhood Cancer Initiative. So their goal, and I'm sure most of the PEDS healthcare professionals know this, they want to improve survival by 60%, which is a million children in the next decade. Well, it started in 2020, and we're approaching 2030 very fast, but that's their goal. And they highlighted 6 cancers where they thought they would get the most bang for buck, and that's the 6 that I've mentioned: leukemia, Burkitt's lymphoma, Hodgkin's lymphoma, retino and Wilms tumor, and also low-grade gliomas. Interesting if you look, so these are from the whole GIC document. So understanding the disease burden specific to the continent is something you need to get your head around. So those circles are the different colors in the different places on the globe. If you look for the high-income countries at the top, those 2 circles, acute lymphoblastic lymphoma, leukemia is something they treat a lot of, along with Wilms and Ewing's. But if you look down at us, we've got lots of Burkitt's lymphoma, retinoblastoma, and Kaposi sarcoma, which shows the different diseases that are driven there. How we need to improve our survival rate, so you can see the incidence and mortality. All I want you to see here is how we've got a high incidence and not a good cure rate. So this is a slide from Esther at Prost in Sydney. She did a very valuable research questionnaire that she sent out to a few pediatric specific centers treating children. And they highlighted their challenges in treating peds. The 2 big ones were the child-friendly equipment and immobilization, as well as issues with access to sedation for pediatric radiotherapy specifically. And the other 2 were staffing, so resources are always an issue, and human resources in particular, and then the complexity of plans and the lack of protocols and standardizations for the equipment and the level of service they could offer. I'm going to touch on a few things, some out of here and some that I thought were interesting as we go along. I have less time than Henriette did, just saying. So this is my MDT flower, so you can decide how many petals in your flower. The more petals, usually the better, and for peds, there are a few more, so you know who we need. I'm not going to list them by name. But the big thing is, before you advise a management plan, and we try to stick to this in our complex, is to involve as many members of this team in the decision-making before you've offered a management plan. And I think that's something you can easily institute if you're not doing it already. Even if you can't be in the same room, COVID's taught us how to be in a virtual room. Try to agree to a weekly tumor board meeting if you're not already doing it for upcoming new patients. We find it the best way. Simple things you can do. So if you've got lots of money and you can decorate a room, that's fine. But you need to start with some small achievable goals. So a group of staff get together and paint the waiting room a child-friendly color and bring some donated toys already. That will start looking better. Friendly staff will make children and families feel at ease. So don't put the people who don't like children in the children's waiting room, because that's not a good idea. And there are those people, no judgment. And we don't have the privilege of play therapists and specific children's psychologists. And this is where people's natural talents dealing with children helps. So we have a whole team that participates. So the whole team are the play therapists. Ways to allow kids to know what to expect. So that's our play area. It was donated by a local NGO, Reach for a Dream, so we were very privileged, and they do it around the country, so I'm not sure, and I can find out from them what exists in other places. I know they have several partners. But again, so from the Children's Cancer Group and then the Birmingham Hospital, one's a a book for kids to page 2. I can share these with you. And the other one is this one about radiotherapy. It's from Birmingham Children's Hospital. It's a beautiful video, just telling kids about this magical rays that are not going to hurt and what to expect if you're having abdominal or a cast, radiotherapy with a cast. So very helpful. We are allowing our children who like to watch screens, which these days are most children, to watch these videos. So sedation for pediatrics, a big deal. I know we are privileged, but it wasn't without a bit of a fight. So in 2015, 2016, one of the drugs we were using to sedate, so when I was Jeanette's registrar, she used to sing lullabies and shush everyone in the room after we sedated children ourselves with various things that were available with the pedongs help. And one of those drugs was discontinued, and that was a gap to try and appeal to the managers of the 2 complexes that, so we get children referred from Red Cross, but all kids are treated at Curtis Gear. It's the same hospital complex. For those 2 sets to provide resources for us to have a half-a-day pediatric sedation list for radiotherapy. I mean, explaining to non-cancer, non-pediatric individuals why you can't do radiotherapy just on Tuesdays was a challenge, but we got there, and so that exists. The other thing that made this possible is a drug called Precedex or dexmedetomidate. So this is used for the diagnostic MRs, actually originated in cardiac ICU with adults. It's good for non-painful procedures, so that's what we use. It's expensive by the vial, but it saves in vast other costs if you don't have to give a full general. Its only downside is that it's IV, can be used intranasally, so the child needs access. But we find this working very well. And the pictures at the bottom you'll see, I know Aggie is going to tell you all about the avatar. We were very excited running around Curtis Gear with Aggie's hand luggage avatar that she brought down that fits onto our TrueBeam. But for children who are at that borderline age, where you know that you could convince them with a little bit of coaxing without terrifying them, to lie still. And definitely for the abdominal treatment without a mask, they're younger. And even for a cast, I know Aggie said they did a child as young as 2. And speaking to them before they start. So try to go with no sedation, it's definitely better. I'm going to speed up here a little bit. So the bunkers that are safe and spacious, so this is not our bunker. This is a bunker in the Northern Hemisphere. But it's under the sea. So look at your recovery areas. If you're designing a new bunker, think about whether you want wall oxygen, gases, where you'll fit your anesthetic machine, and make sure that your resus trolley has PED-size equipment. You don't want to be caught out when you're actually doing a resus. We haven't had to resuscitate any children, but we have had to use tiny pieces of equipment for other things, and luckily we had them. So I'm just going to jump ahead. Another thing that's easy to do, and this is about the quality of your radiotherapy if you want to improve outcomes. Peer review or having your colleague look at your work is something you can do. You just need to make a time and stick to it. So it's been shown that this definitely improves the quality of your work and patient outcomes. It's called the 4I principle. In other corporate centers, if you get 2 people with similar expertise, you're going to get a better result. And I've just put this difficult cranio that we showed in one of our peer review. There was a lot of discussion about the prepontine cysts, which was included, and then you have ways of grading your peer review, if it's a minor change, a major change. So that's something you should try to do. With regards to dose constraints and contouring guidelines, there's so much out there. Use the resources at your disposal, but appropriately. You can't pick a contouring guideline for a VMAT technique if you're doing 3D. They're completely different. So you can't change one thing. You need to change the whole system if you are able to. But I just put this down here because we recently changed from craniospinal, our craniospinal treatment about a year or 2 years now to VMAT. So we had to update the way we contour. You're welcome to these slides. Protocols. Clinical and radiotherapy protocols are something you should try and standardize. If you do something off protocol, you need to note those. Clinical practice guidelines also readily available. These are lovely sets because they adjust the guideline for what your center is able to offer at the different levels of service. You'll see an article from Jeanette and her group, and then the one from Mark Gaze. And then very exciting, the ARIA guideline. I say the Hodgkin's lymphoma one is already up and running. It's free and you just sign up for it. And then there's the international IEA document, which is also being finalized. So lots of help for those trying to treat peds. Again, with the survivorship and long-term follow-up guidelines, there are lots out there. There's the Children's Oncology Group, late effects for adolescents, but make sure you send a report back with the indication for the radiotherapy, the area treated, the dose and fractionation, and the plan and dose to your referring physician. And make sure that the patient knows details about their tumor, that they had radiotherapy, what it was for, what type it was, and what their long-term side effects might be. So continuing education, twinning, and partnership, I can't stress this enough. So we need to help each other. So Prof. Mayosi, the late Prof. Mayosi used to say, you lift as you rise. So we are here in Africa, we're together, we can go together. These are things that are happening in South Africa, but there are lots of other things. So I know that you'll probably hear about access to care and the pediatric brain tumor workshop, but those are happening. I'll just put the conclusion slide. I know my time's almost up. The conclusion slide from, I was so proud because in PROS, when we were listening, Anne Rugwe, who's a fellow of Pauline Njoki and Jirani, who's an ex-Radonc trained but leading the team in Kenya, she just basically did an audit of her womb's outcomes. And since Pauline's been back, they have locally advanced disease, but they've been using the radiotherapy according to the SIOP protocol, and the outcomes have improved. Changing techniques, so please exercise caution. When you change a technique, that's when the most mistakes happen. Make sure your volumes and your QA adapt to the change in technique. And then the proton conversation. So if a family wants protons or you're discussing protons, you need to think about whether the theoretical benefit for that particular case is worth moving that individual and costing them resources. If it's really a big gain, then it's worth exploring. If the gain is marginal, they should probably stay home and get the photons that do very well with their support. And then I just put this here, courtesy of Julie Vera, our brachy specialist, and Prof. Stannard and Hamza Mushtaq. If you want to travel in Africa and you have retinoblastoma, not only protons are worth traveling for, so just bear that in mind. This is just a picture of our advocacy program. So that's CHOC, who support us and Reach for a Dream, and you'll see the kids making pizza. We had a pizza making day, and one of our kids who wanted to meet the Springboks. We love rugby in South Africa. And I think I'm done. So that's an old African proverb. If you want to go fast, go alone. If you want to go together, go far, go together. And then that's my village. And I want to thank Jeanette Parks, who's my mentor and professor of pediatrics, and Esther, who's here somewhere. She's hiding, but thanks, everyone.
Thank you, Dr. Naiker. Next, I'd like to ask Dr. Arnold Paulino to present on Wilms tumor disease and management overview.
Okay, thank you very much. So, I come from MD Anderson, which is in the United States. But although I practice over there, I was actually born in the Philippines. I was an immigrant as a teenager, and I have a special interest in the LMIC countries. So this is what we're gonna learn. Okay, so the first slide actually shows Max Wilms. So this is the man behind the eponym of Wilms tumor. So he was a German surgeon who first did a monograph in 1899 on Wilms tumor, but he is not the first one to describe Wilms, because that was described even in 1814. So ironically, even though we call it Wilms tumor in North America, it is named after a European. The Europeans call it nephroblastoma, and they don't call it Wilms tumor. So figure that out. So this is one of I would say like the model for pediatric oncology in the United States of the success of pediatric oncology, because Wilms tumor was really not very curable in the early 1900s. But you can see that somewhere in the early 1970s, it became very curable. We added radiation therapy in the 1920s, but that didn't really help very much. And then monoagent chemotherapy was used, but it's actually when the NWTS, the National Wilms Tumor Study, originated, and that's when we had excellent, better survivals for Wilms tumor. And as far as radiation oncology is concerned, we should be proud because we actually are part of the history of NWTS because it is actually a pediatric radiation oncologist who was the primary investigator for the NWTS 1, 2, and 3, and that's Dr. Giulio De Angio, who is considered the father of pediatric radiation oncology. So in the United States, there's only 450 cases, but it's the most common abdominal tumor of childhood. 3.5 years is the median age, and you can see here, the epidemiology. In the United States, it's relatively more common in the African American children. And if you look at different continents, like for example here, Nigeria has a relatively higher rate compared to, for example, Brazil or the Caucasian patients in the United States. And then in East Asia, it's not as common. So there are some anomalies associated with Wilms. Aniridia, which is found in about 1% of Wilms tumor patients. You can have hemihypertrophy, such as this particular child, where half of her body is bigger compared to the other half. And this is found in about 2 to 3% of patients. Beckwith-Wiedemann syndrome, which is also associated with other kind of childhood cancers. But by far the most common anomaly in Wilms are the GU anomalies. Undescended testicles, hypospadias, and this is a big problem when you have a horseshoe kidney, in a patient with Wilms. So as far as molecular biology is concerned, there are some important things, that are being considered in the studies in North America, and these are the loss of heterozygosity at 16q, at 1p, and also 1q gain. So these are found in about 20% of Wilms, 10%, and 1q gain is found in about 30% of Wilms tumors. So why are these important? Because they are adverse prognostic factors. So in the NWTS 5, Dr. Grandi published this paper, and as you can see here, for stage 1 and 2 patients, and for stage 3 and 4 patients, if you look at this loss of heterozygosity at both 1p and 16q, they have a worse relapse-free survival. And then this is a publication, a more recent publication looking at 1q gain, which essentially shows the same thing. Patients with presence of 1q gain, which is here in mustard color, have a worse event-free survival and overall survival. So what is the common clinical presentation? Well, in the United States, it's a painless abdominal mass. And pain is usually just seen in less than 25% of the patients. Okay, so this stopped working. Oh, no, it worked. Okay, so what do we do as far as the workup? We do a CT scan of the chest, abdomen, and pelvis. In some renal tumors, we do other kind of imaging. In clear cell sarcoma, for example, we look at the bone. For rhabdoid tumors and clear cell sarcoma, we look at the brain. sure why. Okay, so this is an example of Wilms. And you can see here the claw sign, meaning the mass is originating from the kidney, and there's lymph node metastasis in this particular patient. So is there another way of... So this is a favorable histology patient. The classic picture is triphasic, where you have stromal, epithelial, and blastemal elements. So the question is there any prognostic significance regarding the type of, Wilms tumor you have? So in the SIOP series, where they give preoperative chemotherapy, at nephrectomy, when you find blastemal predominant disease, those patients actually do poorly compared to other histologic subtypes. Okay, so there are two approaches for treating Wilms. We have the North American approach, where you try to do the immediate nephrectomy. The European approach is to do chemotherapy first and then nephrectomy. So the advantage of the North American approach is the stage, the histology of the Wilms tumor. The advantage of the European approach is you use less radiotherapy in their patients. And the reason why you use less radiotherapy is because you lower the risk of getting a rupture when you do preoperative treatment. So initially in SIOP 1, they use radiation therapy as the preoperative treatment, and you can see if you do immediate nephrectomy, 32% had a rupture versus 4% with preoperative radiation. And then in SIOP 5, there was a comparison of preoperative chemo versus preoperative radiation, showing essentially the same proportion of rupture, but because the pediatric oncologists trying to avoid radiation, preoperative chemotherapy became the standard. So the staging system we use is the NWTS staging system. Stage 1 is limited to the kidney. Stage 2 is limited. There's extension outside of the kidney, but completely removed. And stage 3 is if you have some type of residual. So this is stage 3 patients are the ones that we give radiation therapy in North America. So these are patients with positive margins, or if you have gross tumor, if you have some type of spill, if you have preoperative rupture, if you have peritoneal metastases, those will be considered as stage 3. Stage 4 is if you have distant metastases. The most common site of distant metastasis in Wilms are the lungs. And of course, stage 5 is unique to Wilms. It's bilateral Wilms tumor. So in the NWTS experience, you can see here about 2/3 of the patient will not need radiation because they're stage 1 or stage 2. And about 20% of the patients are stage 3. So these patients will need radiation therapy. And as far as stage 4 and stage 5 patients, depending on the situation, some of these patients will get radiation therapy. So in the NWTS 1 and 2, what Dr. DeAngio found is if you have a stage 1 patient, you really don't need to give radiation therapy, provided you're using 2-drug chemotherapy, vincristine and actinomycin. However, in NWTS 3, there were 2 randomizations. For stage 2 favorable histology patients, there was a randomization for radiation versus no radiation, 2 drugs, actinomycin, vincristine, versus 3 drugs with addition of the adriamycin or doxorubicin. And this showed that if you are a stage 2 favorable histology, you don't need a 3rd drug, and you don't need radiation. So this became the standard. For stage 3 patients, there was a randomization. between 10 gray versus 20 gray, 2 drugs versus 3 drugs. And what they found is that if you use the doxorubicin or the adriamycin, you don't need to use a higher dose of radiation. You can stick with 1,000 centigrade. And that's been the standard for decades in the United States, is to give we do 1,080 centigrade because we give 180 centigrade for fraction. So I'm not going to go over the timing of radiation therapy because of our limited time, but let me talk to you about this study that was published within the last 10 years. And these are the stage 3 patients. And as I told you, these are the patients who are getting radiation. If you look at which patients who are getting radiation are doing worse, it's actually the patients who have lymph node positive disease. Okay? And also patients who either have an LOH1P or 16q. Okay? And so in the past studies, we've always combined the LOH1P and 16q, but now if a patient has lymph node positive disease, either of those two are actually bad. And so in the next study, this will be an adverse factor, and those patients will be getting more therapy, lymph node positive with either 1P, 16q. Okay, so this has been a question when I was even a resident, and probably until now it's still a question. Who needs radiation therapy, for those patients with lung metastases? So the retrospective study from NWTS 4 and 5 showed that the addition of doxorubicin actually improves the 5-year survival. Okay, but if you look at whole lung radiation therapy, although the numbers may look like they might be better if you give whole lung, it was not statistically significant. So in the last COG study, 533, what we did was we looked at the stage 4 favorable histology patients who had lung metastases only. So these are patients who don't have liver metastases, and these are also patients who didn't have LOH1P and 16q. So they got 6 weeks of chemotherapy. They got the triple drug chemotherapy. Okay, and then after 6-week evaluation, if they have a complete response, you continue with the triple drug chemotherapy and you don't give whole lung radiation. However, if you didn't get a complete response, you got 2 more drugs in addition to the 3 drugs they are getting. Okay, and then you get whole lung radiation. So this is looking at the patients who didn't have a complete response. So about 55% of the patients didn't have a complete response. But as you can see here, the event-free survival was 88.5%, and the overall survival was 95.4%. This is the best that has been reported in the literature. I mean, we're dealing with stage 4 patients. If we look at the complete responders, and there are about 45% of these patients, the 4-year event-free survival was only 79.5%. The overall survival, 96.1%. So the survivals are comparable, 95, 96%, but the event-free survival seems to be lower for the complete responders. So is it because we didn't give those regimen M, the extra 2 cycles, or is it because of the whole lung radiation? So this is one of the questions that we have. So in the next COG study, what we're going to do is we're going to give whole lung radiation therapy to the 1Q gain patients, that I was talking to you about that have adverse prognostic factors, and also if they have a lymph node positive disease that have either a 1P or 16Q. Okay, so these are the current COG guidelines. So no radiation for stage 1 or stage 2. Stage 3, you give abdominal flank radiation. Stage 4, depending on the local stage, you may need abdominal radiation. And then it also depends on your response to the chemotherapy. Okay, so what do we exactly treat? Well, we treat the tumor bed. We cross the midline to include the para-aortic lymph nodes. Okay, and we give 1,080 centigrade in 6 fractions. Now, in the case where we have peritoneal seeding, or we have a preoperative rupture, or during surgery, you create a diffuse spill, then you have to do whole abdominal, which is kind of like a misnomer, because whole abdominal actually is whole abdominal and pelvis. And you give 1,050 centigrade in 7 fractions, so we lower the fraction size for the bigger fields. For the metastases, as I mentioned, for the lung radiotherapy, we typically give 1,200 centigrade in 8 fractions, although in some of the younger patients, we might use 900 centigrade in 6 fractions. Liver metastases usually gets a higher dose of radiation, whether they're more radio-resistant or not. You know, we don't really know, but that has been what has been done in the NWTS, and we've continued to use that dose. So just an example, we have a 2-year-old boy, and he has favorable histology Wilms, the right kidney. So during the nephrectomy, he had capsular penetration only. So this will be a local stage 2. Okay, but the patient also has pulmonary metastases. So because the patient has local stage 2, they don't need radiation therapy to the abdomen. But the question is, do they need lung radiation? So the patient had residual pulmonary metastases after 6 weeks of chemo, and so the patient needed whole lung. We gave 1,200 and 6 fraction, and this is what was given. And in the previous COG study, we have to give the lung radiation APPA fields. So this is another case where we have a local stage 3 favorable histology patient. And you can see the massive tumor there. But also you can see lung metastases, and you can see liver metastases. And I don't know, this might be similar to some of the patients you're seeing over here, but to us, this is like really, really, really advanced. So what did we do for this patient? So this patient, you know, if we do APPA fields, you know, we're gonna overdose the only remaining kidney. And so it's not a very good idea. So luckily, you know, we have IMRT, and so that's what we did. You know, you can see here how, and the other thing we did on this particular case is we did like a cardiac sparing whole lung radiation therapy. And so you can see here the doses that we delivered, 1,050 centigrade to the left renal tumor bed, 1,200 to the bilateral lungs, and 1,920 to the entire liver. And then this is another case, a stage 3 patient. The initial presentation is, you can see this, you know, mass over here. But here in the pelvis, there's another thing, you know, there, which was considered peritoneal metastases. Okay, so the patient got preoperative chemotherapy. We didn't do a nephrectomy up front. We gave chemotherapy. Both of them masses shrunk, and they did surgery to remove both masses. And so what we did is we did whole abdominal radiation therapy. And we gave 1,050 centigrade in 7 fractions. Okay, so the problem with the previous COG study is that if you needed flank or abdominal radiotherapy, you would give it within 2 weeks of the surgery. And then you have to wait another 6 weeks to determine whether the lungs need to be treated. Well, that's good if the patient doesn't need radiation to the lungs. But that's not actually so good if you need whole lung radiation, because what will happen is you will actually double the dose, you know, to the liver or to the stomach or to the heart, you know, depending on what side you're treating. So in the next COG study, we're changing this. for stage 4 patients, all abdominal radiation therapy will occur after 6 weeks, which should coincide with the whole lung radiation. Okay, another controversial thing. Should we continue doing APPA fields like this, or should we be doing more targeted fields like this? Now, in every other tumor that I know of in pediatrics, we're not doing this. Neuroblastoma, we've changed. We're doing more involved field radiation therapy. So in the COG, we actually discussed this, and I brought up, the fact that we're the only site that's still doing this. But, in the next COG study, we're randomizing chemotherapies, different regimens. And so if we change the radiotherapy fields and we change the chemotherapy, it would be very difficult to know, if we had a worse outcome, which was the culprit. And so, since they're not eliminating radiation, which is good, we're trying to eliminate doxorubicin in the next study. What we decided is we're going to continue doing the APPA fields, and then for the next study after this, think about the reduction. And the reason why we're not too concerned is because our local control actually is pretty good. It's about 95%. And the late toxicities are not very much with 10 gray. And I know the Europeans are doing the involved field radiation. They're also giving they're giving 14.4 gray, and sometimes even 25.2. Okay, so bilateral Wilms. So how do we approach these patients? These are not very common. They're about, you can see about 5% of cases. But there's something to learn about these tumors. If you look at the 5-year survival, usually they're in the mid-70s. 10-year survival, they're in the 70s. Okay, so that's like your historical group. So there was a prospective study done in Children's Oncology group. And what we did was we gave chemotherapy, 3 drugs. We tried to do partial nephrectomies on both kidneys. Okay, and then depending on what we find in the surgery, you continue the chemotherapy, but sometimes you might need to give radiation therapy. So this is that particular study. So after 6 weeks of the triple drug chemotherapy, they're evaluated. If you can do surgery, especially partial nephrectomies on both sides, go ahead and do it, okay? If you think that the tumor is still gonna shrink, then you can give another 6 weeks of chemotherapy, okay? But after 12 weeks of the initiation of chemotherapy, you have to do surgery, okay? And in the past, sometimes I've seen cases where they're giving chemotherapy for like a whole year. And that's not actually good according to this study, because in this study, our 4-year overall survival was 94.2%, event-free survival 81%. And I showed you, this was like in the mid-70s. So this is also the best that's been reported for bilateral Wilms tumor. So the lesson from here is that you have to do the surgery within 12 weeks of initiation of chemotherapy. So what's disappointing in this study is only about a third of the patients had partial nephrectomy. So this is one of the things that we're gonna try and improve in the next bilateral Wilms tumor study. Okay, relapse Wilms tumor, all I can say is it's bad. Even though Wilms tumor favorable histology is very curable, once they relapse, they don't do as well. So the first time around is the best time to treat them correctly. Okay, and just a mention about anaplastic Wilms. These are worse compared to the favorable histology patients. There are 2 types. There's the focal anaplasia and diffuse anaplasia. And as the name suggests, focal anaplasia does better compared to diffuse anaplasia. But notice a subsequent NWTS and COG study, the stage 4 diffuse anaplasia, I mean, most of the patients died in NWTS 3 and 4. NWTS 5, about 1/3 of the patients did okay. And then in the COG study 0321, about half of the patients survived, which is like a major achievement. You know, one of the reasons for this is the addition of more chemotherapy agents such as carboplatin. But the other is that we increased the dose of radiation. Instead of using just 10.8, we used 19.8 gray, and we had less local failures. Okay, so these are the outcomes of overall survival for anaplastic Wilms. So these patients need further improvement. Okay. Okay, I guess I cannot go back. Okay, once okay. So anyway, so what are some of the complications of radiation? Okay, the bone can be affected. You can have scoliosis, you can have iliac wing hypoplasia, decreased bone growth. The kidneys can be affected, but if you have a unilateral Wilms, usually it's 1% or less. Bilateral Wilms usually is double digit. Patients who are getting whole lung radiation therapy, you know, about 4 to 5% of those patients might have some kind of pulmonary disease. And then finally, cardiac toxicity. You know, again, it's probably around 5% for those treated, you know, for the initial disease, you know, but it's more common in patients who got, you know, left lung radiation and also whole lung radiation. And so that reason for trying to do cardiac sparing whole lung radiation. Okay, so I put this particular painting. This is a painting by an American painter, Mary Cassatt. And every time I see this painting, it reminds me of Wilms tumor. Because this is actually how the parents discover the patient, you know, has something wrong with them because their bellies are getting bigger when they're bathing them. Okay, so to conclude, we have current excellent survivals in North America, you know, with Wilms tumor. We have tried to reduce radiotherapy in selected subsets of patients who have better prognosis. But the other thing is we've also been more aggressive, you know, for some patients who have adverse biologic factors. In some patients with favorable histology, Wilms tumor and lung metastases, we've eliminated the whole lung radiation therapy without compromising overall survival. And then the last thing that I want to make sure you knew is bilateral Wilms tumor is treated with chemotherapy, planned surgery by 12 weeks of diagnosis, with or without radiation therapy. Okay, well, thank you. Case presentation.
Thank you, Dr. Paulino. I'd like to now just follow up with Dr. Sikudhani Muya, who's going to discuss a pediatric case, Wilms tumor, from Ocean Road.
Good morning. So my name is Dr. Muya. After a good discussion on Wilms tumor, I'm going to take you on a case of a child with Wilms tumor that we treated at Ocean Road Cancer Institute, Tanzania. So she was a 5 years old who presented with a 6-month history of abdominal discomfort and the gradual abdominal swelling. And she was referred to us for radiotherapy from Pediatric Oncology, that is from our national hospital, so it's called Muhimbili National Hospital, with a diagnosis of Wilms tumor. So she had a right atrium thrombi and IV thrombus. And at Muhimbili National Hospital, she had received a neoadjuvant chemotherapy, a VAD, That was followed with right nephrectomy. And post-operative histology shows blastemo predominant. And so she was sent to us on the 9th day of post-surgery. She was in good ECOT status. And per abdomen, the scar was well healing, and there was no any palpable mass. The blood, all the bloods were okay. And she was booked for CT simulation. And after that, contouring was done, and planning was done and reviewed. So she was started on whole abdomen radiotherapy a week after. So these are the dose distributions. And so the contralateral kidney was getting the mean dose of 1.7. And I think that's the most important part. And that was it. After radiotherapy, we sent her back to Pediatric Oncology to continue with her adjuvant chemotherapy. That was it.
Thank you, Dr. Muya. Next, I'd like to invite Dr. Esther Majaliwa, who's going to review some more Wilms tumor, but research they're doing at her institution.
So I guess this is the last talk about Wilms tumor, no more after this. I would like to thank Dr. Paulino for setting up the ground for my talk. And so as introduced, I'm Dr. Esther Majaliwa from Kilimanjaro Christian Medical Center in Tanzania. And I'm here to present one of our clinical reports, which has a title of Novel CTR9 Germline Pathogenic Splice Site Variant in Siblings with Wilms Tumor from Tanzania. So this is the outline of my talk, and I have nothing to disclose. And one more thing, I'm not a radiation oncologist. Okay, so the two pictures shows the center that I work. So the bottom picture is the inpatient ward, and the top picture shows the connection of the inpatient ward connecting to the clinic and the infusion, and at the back is the radiation center. So KCMC is the third largest hospital in Tanzania, located in the northeast part of Tanzania, with a catchment area of around 15 million people, and it is the only comprehensive cancer care center in the region. And we have around 35 bed capacity, specifically dedicated for the pediatric oncology unit. And at KSMC, we see around 150 cases of new child malignancy each year, and around 18 to 20 of these are Wilms tumor. So globally, it is said that approximately Wilms tumor contribute approximately to 6% of all childhood tumors. And we have heard from Dr. Paulino that it has an ethnic diversity, common in Africans and Afro-Americans, very less in Asians. So there are around 1 to 2% of Wilms tumor, which is attributed to familial, often associated with de novo pathogenic variant. And usually familial Wilms tumor have early age presentation, and it has increased risk of bilateral disease. And it is said around 13% of patients develop bilateral Wilms tumor. So it was reported that around 5% of Wilms tumor is related to well-known genetic Wilms tumor predisposing syndromes. And some of these syndromes can be categorized into the genitourinary malformation and overgrowth syndrome, and whereby we heard about this syndrome being Weger, Dennis-Drash, Beckwith, and Pellman syndrome. But however, we do have 4 genes known to be involved with non-syndromic inherited Wilms tumor, and these are the WT1, REST, TRIM28, and CTR9. And we have heard about the loss of heterozygosity, which is a contributing factor in, to poor prognosis in patients with Wilms tumor. So, so far, there are 4 Wilms tumor family which have been described with pathogenic variant in the CTR9. And in the 3 families, this was a splice site variant for which loss of exon 9 from the transcript was expected, leading to deletion of the exon. So I would like to take you through the cases which led to this talk, to this clinical report. And the first case is of a 1-year-old female who presented with abdominal distension for around 2 months. On examination, so she had normal vitals, she had no dysmorphic features, and her milestones were appropriate according to her age. Upon her systemic examination, on abdominal examination, she had a non-tender mass, which was located on the left side, which she also had normal bowel sounds. Her cardiovascular and respiratory system were all normal. Her blood works were normal, and upon further imaging, a CT abdomen showed a left renal mass with no calcification or encasement of the vessels, and her lungs were clear. So we have heard about the European protocol, which is the SIOP, Wilms tumor protocol, which the patient was started, and it included 3 drugs, vincristine, dactinomycin, and we usually give 1 dose of doxorubicin because of the bulkiness of the disease that we see. And then thereafter, the patient went on to get a nephrectomy, and the histology came reported as a tumor occupying around 95% of the kidney, which was homogeneous. It had necrosis at the center. It was extending into the renal sinuses and capsule and had a vascular invasion. So the tumor had a blastemo-stromal and epithelial triphasic pattern with no features of anaplasia. And this was staged as a stage 2 intermediate risk by the pathologist. So therefore, the patient went on to receive adjuvant chemotherapy, which included doxo, cyclophosphamide, etoposide, and carboplatin, and then completed a treatment successfully, and good enough, there was no recurrence at 3 years of follow-up. And then about a year later, we received a second patient who was a 7-month-old female who was a younger sister of patient 1. So she presented to our hospital with a right-sided abdominal swelling, which was noted by her mother during changing clothes and taking baths. So we heard about this. And the mass was progressively increasing in size with no constitutional symptoms, though later there was reported, weight loss was reported. So upon examination, she had a normal motor and cognitive development. Her abdomen was asymmetrical, distended with a non-tender palpable mass on the right upper and lower quadrant, had a normal bowel sound. Cardiovascular and respiratory exams were normal. So her blood works were also normal at the time of diagnosis. Her imaging CT abdomen showed a bilateral Wilms tumor with a well-defined heterogeneous mass arising from the right kidney, measuring 9.6 by 7 by 10, and a second smaller mass arising from the lower cortex of the left kidney, measuring 3 by 3 by 3. Her chest was clear. And this is the initial scan of patient number 2, on the right side showing a well-defined heterogeneous mass with the measurements located, and on the left side it shows a smaller mass arising from the lower cortex. So the patient then went on to receive neoadjuvant chemotherapy according to the SIOP protocol for 8 weeks. After chemotherapy, the right tumor had reduced to 6 by 5 by 5, and there was no tumor noted on the assessment imaging on the left kidney. And therefore, a nephrectomy was performed on the right kidney, but unfortunately, the surgeons did not take a biopsy at the local site of the left kidney. She also had some enlarged lymph nodes, which were fortunately removed during surgery. So her histological report came back on the right side. There was a capsulated specimen that was 6 by 4 by 3 in size, with a nodular tumor occupying 2/3 of the surface, measuring 4 by 3. So there was no capsular, ureter, or hilar vessel involvement. The tumor had a triphasic pattern with a predominant epithelial component. The lymph nodes showed a reactive changes. So although it was stage 5 because of the bilateral Wilms tumor, the right kidney was reported at stage 1, intermediate risk, and we didn't have any tissue on the left kidney. So as clinicians, we were wondering, could this be nephrogenic rest? So the child completed 26 weeks of adjuvant chemotherapy, and surprisingly, her 1-year follow-up scan after treatment showed that there was a small mass on that left kidney, which was 1 by 1 by 1. But we didn't do anything, so we followed it up with scans, and luckily the tumor remained unchanged throughout the subsequent scan. So, because of the history of Wilms tumor in these 2 siblings, and then one of them having a bilateral Wilms tumor, we thought whether these 2 cases could be attributed to some sort of a genetic component. So we took a venous blood from both patients and their parents, and these samples were sent to Nijmegen, oh my God, the Dutch, in the Radboud University Medical Center. And if you may wonder, like, why in the Netherlands? And this is because we have a long-standing relationship with Radboud University, whereby our pathologists usually send samples for second review through telepathology, but also we have a visiting professor who usually come and build capacity. So the samples were able to be analyzed for free, and through using exome sequencing, so we found a heterogeneous pathogenic variant was detected in one of the genes associated with hereditary tumors. So the pathological gene was a CTR9 in the position of 1194, and whereby the guanine was replaced by adenine. And so this gene, actually it changes the consensus donor splice site sequence of exon 9, and therefore most likely leads to altered splice that prevents the formation of normally functioning protein. And this gene had never been described before in the literature. So Hanks et al. Had described on the same position of 1194, thiamine was replaced with cytosine, and on the same position, adenine was replaced by cytosine. So based on the above argument, this variant was classified as pathogenic variant class 5. The same heterozygous splice site variant was found in patient 2, so in both sisters and the father, but the mother did not have this pathogenic variant. So we further analyzed tumor material from patient 1 and identified loss of heterozygosity with loss of wild-type allele of CTR9 locus. And we already know that loss of heterozygosity is associated with poor prognostic factor. So coming into our discussion, so CTR9 gene, we know that it's located at chromosome 11, short arm 15.4, and encodes a component of the polymerase-associated factor 1 complex, which is associated with RNA polymerase 2. So it is a complex protein that transcribes DNA into messenger RNA and other nuclear RNAs. And the PF1 complex is also involved in the regulation of gene expression, DNA repair, and cell cycle, which explain the tumor development. So further, in our study, we describe the 5th Wilms tumor family with a novel heterozygous germline pathogenic variant in CTR9. And it is also the 4th in which the identified variant changes the consensus splice site sequence of exon 9, and the 3rd in which loss of heterozygosity with the loss of wild-type allele was found in the tumors. Now, if you look at the other 4 families which have been described in literature, together with our study, all of the children had early diagnosis compared to the general mean age diagnosis of Wilms tumor, which is 3.7 years in unilateral case and 2.6 years in bilateral case. And in all studies, the pathogenic CTR9 variant was paternally inherited. So now looking at comparison, specifically on the characteristic of Wilms tumor families with CTR9 pathogenic variant, looking at our study. So our study found in the position of 1194, the guanine was replaced with adenine, and this resulted in a splice site. And we presume that it led to deletion of exon 9, just as it was described by Hanks, whereby we had a pathogenic variant in the same position. And the tumor, we also found loss of heterozygosity in the tumor. And also, it involved two siblings, and the father being the carrying variant, which was also similar in most of the 4 studies which were described in the literature. And also, out of 3 of the carriers of this pathogenic variant, 2 of them developed the disease, which was also similar in other studies. Conclusion. So, we report the 5th Wilms tumor family with a novel heterozygous germline pathogenic variant in CTR9. It is the 4th in which the identified variant changes the consensus of the splice site sequence of exon 9, and the 3rd in which loss of heterozygosity with a loss of wild type allele was found in the tumor. And thus, with this study, we cement or we strengthen the idea that CTR9 is a tumor suppressor gene and that the in-frame deletion of exon 9 is developed in the inactivation of CTR9 and WT development. And this report was published in the European Journal of Medical Genetics. You can check for more information. And lastly, Karibu Moshi, Karibu Tanzania. Thank you for listening.
Thank you, Esther. We have a short break that will meet back at 10:40. And the break, there's coffee and tea right outside, and we'll come gather you all when it's time. Thank you.